Diagnostic criteria in asthma. First is the medical history, second is the physical examination, third is the lung function test and additional testing. So medical history comprehensive symptom assessment including nocturnal cough frequency, wheezing episode and shortness of breath pattern. Document specific triggers like dust mite, pet dander, pollen, cold air, exercise. Symptom seasonality and family prevalence of asthma or atopy. Note age of the onset to differentiate childhood versus adult onset pattern. Assess impact on daily activities, sleep quality and work or school performance. Record previous asthma examination, emergency department visit, hospitalization and ICU admission to establish severity history. Document comorbidity like GERD, obesity or sleep apnea that may complicate management. Now let's start with the physical examination. Thorough auscultation for expiratory wheezing, prolonged expiratory phase and decreased breath sound. Assess upper airway on nasal polyp, rhinitis and sinusitis which occur in 60 to 70% of allergic asthma. Examine for dermatological manifestation of atopy and evaluate respiratory muscle use during breathing. Look for sign of respiratory distress including tachypnea, intercostal retraction, nasal flaring and cyanosis during exacerbation. Measure oxygen saturation level at rest and after mild exertion. Observe posture and breathing pattern, noting any barrel-shaped chest deformity in chronic cases. Now the lung function test, spirometry measuring forced expiratory volume in 1 second, that is FEV1, and FEV1 upon FVC ratio with value below 80% suggests obstruction. Document diurnal peak flow variability exceeding 13% for adult or 20% for children. Confirm reversibility with 12 to 15% improvement in FEV1 post bronchodilator administration. Conduct lung volume measurement to detect air trapping, that is elevated residual volume upon total lung capacity ratio. Perform diffusion capacity testing, that is DLCO, to rule out alternative diagnosis like COPD or interstitial lung disease. Consider bronchoprovocation testing in patients with normal spirometry but persistent symptoms to unmask hidden bronchohyperresponsiveness. Now the additional tests or testings are quarterly blood eosinophil elevated in allergic asthma, measure serum IgE level and Conduct allergen-specific skin prick test for 30 to 40 common allergens. FeNO testing with value more than 25 ppb in adult or 20 ppb in children indicate type 2 inflammation. For non-allergic asthma, consider provocation testing with methacholine at PC20 less than 8 mg per ml confirms diagnosis. Obtain chest radiograph to exclude alternative diagnosis and identify complications like pneumonia or pneumothorax. Consider HRCT high resolution CT scan. Scanning in case with atypical presentation to rule out bronchiectasis, tracheal abnormalities or bronchiolitis. In difficult to diagnose cases, bronchoscopy with bronchoalveolar may identify cellular patterns of inflammation or alternative diagnosis. Thank you.